Okay, let us continue from question number 15. A 45-year-old man who was recently started on medication for paroxysmal atrial fibrillation undergoes stress ECG testing. The patient exercises on a treadmill for 9 months and reaches 98% of age predicted maximal heart rate without chest pain or ST segment changes. His pre-test resting QRS complex duration is 95 millisecond. Normal is 80 to 120 millisecond. Okay, and corrected QT interval duration is 410 millisecond. Normal is less than or equal to 440 millisecond. Okay, ECG findings recording it his maximally achieved heart rate show a QRS complex duration of 1 to 5 millisecond and QT interval duration of 400 millisecond. Okay, based on the patient's test results, which of the following medications is most likely being used to treat his atrial fibrillation? Okay, pause it and give the answer. So the correct answer for this question is flecainide. Why? Let us see to the explanation. Right. Why it's flecainide? Because what will do flecainide? It will prolong QRS complex during exercise. Right. And it is an antiarrhythmic drug, right, of class 1. Okay, like we have four classes, right? Class 1, class 2, right? Then we have class 3, uh, then we have class 4, right? So this one flecainide is class 1, right? So typically it is used to treat supraventricular tachycardia like atrial fibrillation, right? And their mechanism is important where it acts, right? It acts on the fast sodium channel, phase 0 depolarization. This is important, right? Phase 0 depolarization. No effect on QT interval and total action potential. These drugs have no effect. They are talking about this one, class 1C antiarrhythmic drugs, right? They have no effect on QT interval and total action potential. Okay, these are the slowest of class 1 agents. We have three classes, right? Class 1A, class 1B, class 1C. We will talk about that, right? These are class 1C. They are talking about class 1C, flecainide. These are the slowest of the class 1 agents, right? Follow use dependence phenomena, right? They follow use dependence phenomena. We will talk about this, right? Okay, why not atenolol, option A? Because it will not significantly affect the QRS duration, right? What will happen? What will it do? It can limit maximum heart rate during cardiac testing exercise because atenolol atenolol is a beta blocker, right? So what it will do? It will decrease heart rate. So that's why it can limit maximum heart rate, right? Okay, why not digoxin? Not significantly affect QRS duration. These drugs, atenolol, digoxin, and you know all these drugs, they cannot significantly affect QRS duration. Now, what is the other thing regarding digoxin which we have to note it is they can falsely what they can do, false positive ST segment depression. What they can do? False positive ST segment depression, right? They can do this thing. Okay, again, it can limit maximum heart rate during exercise testing, right? Okay, why not dofetilide, right? What it does? what it does is increases the QT interval duration. If we look to flecainide, there was no effect on QT interval duration. But here dofetilide, it has effect on QT interval duration. It will increase QT interval, but it is opposite to the flecainide. Flecainide was what flecainide was doing, that was prolonging QRS complex. You can see over here, it was prolonging QRS complex. It was right, but the ferrylide, it doesn't affect QRS, so it is opposite to that, right? So this is important. So it is a class 3 antiarrhythmic. This is important. That was class 1C, right? But dofetilide, it is class 3 antiarrhythmic drug. Okay, it is potassium channel blocker. Now this is also important. It is potassium channel blocker. We have, as I said, we have four antiarrhythmic classes, right? So class 3 is potassium channel blocker, right? Class 4 is calcium channel blocker, right? Class 1 is sodium channel blocker. These things are important. Okay, we will go through that. So phenomena, okay, phenomena of reverse use dependence, right? This is using phenomena of reverse use dependence, right? What it will does, whenever there is slow heart rate, it will more prolonged QT interval, right? It is opposite. Like uh, we talked about early, one method was dependence phenomena, right? What will happen if there is more heart rate, right? If there is more heart rate, then there will be more prolonged QT interval. So this is a direct relation, right? Direct relation with the QT interval, right? This is dependence phenomena. But here it is reverse use dependence phenomena, right? In case of, I'm talking about in case of dofetilide, it is reverse. If there is more heart rate, this will be inversely related to QT interval, right? This is important. Okay, okay, good. So why not verapamil? As we talked about this, that uh, class 4 has calcium channel blocker. Verapamil is a calcium channel blocker, right? So what it will does, it will slows sinoatrial SA and atrioventricular nodal conduction, SA and AV node conduction, right? What it will does, it will slow down AC node and AV nodal conduction. It's a class 4 antiarrhythmic drug. We talked about this. It's a calcium channel blocker. It increases coronary blood flow. Okay, it will increase coronary blood flow. It will reduce myocardial oxygen demand. This is important. It is reducing myocardial oxygen demand, right? Now this point is important. This point, remember this thing. It will mask it will mask it will mask ischemia during exercise testing. This is important. Please remember this point. It will mask ischemia during exercise testing, right? Because what it does, it is reducing myocardial oxygen demand. Okay, this thing, it doesn't affect QRS duration, right? It doesn't affect QRS duration, just like flecainide, which is a class 1C uh, antiarrhythmic drug, right? So remember these points. Okay, let us see to this thing, right? So it's a ventricular uh, action potential, right? The depolarization is because of fast sodium channel entry. This is important. All right, we will talk about another one, that is SA node in AV node, uh, which is because of calcium entry. Funny channel, which is because of we will talk about those whole phenomena, right? But here you note this point, that here the entry, the sharp, this sharp line, uh, this depolarization is fast, slope is because of fast sodium channel entry, because of fast sodium channel through which the sodium will enter. Okay, then we have the phase of repolarization. There will be calcium entry and potassium out, exit. Okay, then we have this phase, a repolarization phase. This one over here is play 2, right? And this one over here is repolarization, which is because of potassium exit. Okay, then on ECG, we have P wave, that is atrial depolarization, right? Then we have QRS complex, this is representing ventricular depolarization, right? And then we have T wave, this is representing ventricular repolarization. Okay, let us see quickly through this. Okay, QRS complex duration typically slightly reduced during exercise in response to increase in the cardiac conduction velocity. Accompanies faster heart rate. However, this patient QRS duration is normal at rest and prolonged it near maximal heart rate. This suggests that the drug used to treat his AFib lengthens the QRS duration in a rate dependent manner, as I talked about this. Whenever the heart rate is more, the uh, that is directly related to that, right? Okay, consistent with drug existing a strong use dependence is flecainide. Flecainide is a class 1C antiarrhythmic drug. We talked about this, typically used for treating supraventricular attack. We talked about this, AFib, fast sodium channel responsive, phase 0. This is important. Do not forget about this. Phase 0 depolarization. Blocking the inward sodium current. Prolongs QRS duration. Lethal effect on total action potential or QT interval. Right? This is important. Slowest of the class 1 agents, we talked about this, dissociate from the sodium channel. Okay, so primarily during diastole. Use dependence, we talked about this. Sodium blocking effects intensify as the heart rate increases due to less time for medication to dissociate from the receptor. Okay, why not option A? We talked about this, selective beta 1 blocker. Atenolol not significantly affect QRS. Limit the maximal heart rate, we talked about this, it will decrease the heart rate. Okay, why not digoxin? We talked about this, false positives, st segment depression. This is really important, do not forget about this thing. Exercise ECG testing lower the maximal achievable heart rate, doesn't significantly affect QRS duration. Dofetilide class 3 anti-arrhythmic drug blocks out potassium channel blocker, right? We talked about this. Increases QT interval duration, it will increase QT interval but doesn't affect QRS duration. Important, this is important. Okay, class 3 agents. Reverse use dependence, this is really important. Do not forget about the mechanism. Slower the heart rate, as I talked about this, more the QT interval is prolonged. This is important. Inverse relation, right? Okay. Why not verapamil? We talked about this. Verapamil, a class 4 anti-arrhythmic drug, calcium channel blocker, slows SA and AV nodal conduction, increases coronary blood flow, all those things, right? Reduced myocardial oxygen demand, mask ischemia. Verapamil doesn't affect QRS duration. We already talked about this. Class 1 class 1C anti-arrhythmic, flecainide, potent sodium channel blocker. As I talked about this, class 1 is sodium channel blocker, right? Have increased effect at the faster heart rates. Use dependence mechanism, important. More effective at treating tachyarrhythmia, but can also cause prolonged QRS duration. Can also cause prolonged QRS duration, right? This is important. Pro-arrhythmic effect at higher heart rates, right? So like in this case, if we look at this case, The QRS complex complex duration of 125 millisecond. This is being increased, right? Normally it should be 80 to 120, but here it is being raised to 125. Yeah, okay. It make ECG finding recorded it is maximally achieved heart rate. When the heart rate was increased, when the heart rate was increased, right? Let me draw this. Heart rate was increased, so the QRS complex, the QRS interval, right? That was also increased. So that's why it is opted well. It is suited well with flecainide. Okay, good. So we talked about this thing. Now this thing is important. We have three classes in class 1 A, class 1 A, 1B, 1C. Okay, in 1A we have quinidine, procainamide, and disoparamide, right? Then in class 1B, lidocaine, local anesthetic, and mixalatine. Then in class 1C we have flecainide and profafenone. Okay, now these things are important. Inhibition of phase 0 depolarization, this is important because it is a sodium channel blocker, right? Okay, so inhibition of phase 0 depolarization. Okay, class 1, that is intermediate inhibition, that it is doing intermediate inhibition, right? Quinidine, you know uh, used for malaria, those things, and procainamide and disopyramide, they all have inhibition of phase 0 depolarization of intermediate intensity. Okay, class 1b that is weak, okay, and class 1c that is strong. Now this thing is important, effect on length of action potential, right? Here in class 1c there is no change. This is important, no change in action potential, right? While in class 1A, like quinidine, procainamide, disopyramide, it will be prolonged. It will be prolonged. In class 1B, it will be shortened, right? So A, B, C, prolonged, shortened, no change. Okay, prolonged, shortened, no change. Remember this point. Okay, I was talking about this thing, that in pacemaker, the action potential will be little bit changed. Here will be here the the depolarization would be because of calcium, right? Here it is phase 0 is because of calcium, but over there, uh, in case of ventricular ventricle, action potential, that was because of sodium, right? Okay, so yeah, like they have mentioned this, the phase 0 over here is because of sodium, right? In non-pacemaker action potential, right? But here in pacemaker action potential, it is because of calcium. This is important. Okay. Then the other thing like repolarization would be the same, right? Okay. So this thing is important. Okay, the next question, question number 16. 46-year-old man with a 30 peak year smoking history develops right leg pain and swelling after returning from an overseas trip. Okay, he was diagnosed with a lower extremity deep venous thrombosis and started on IV heparin. Shortly after being hospitalized, he develops right-sided weakness and facial drop. CAT scan of the head reveals a left middle cerebral artery stroke. Which of the following physical examination findings is most likely to be present in this patient? Option A, diastolic decrescendo type murmur that decreases following amyl nitrate inhalation. Option B, ejection type systolic murmur that increases on standing. Presystolic murmur that disappears with AFib. Mid systolic click that occurs earlier with inspiration. Wide splitting of S2 that doesn't change with respiration. Pause it and give the answer. Okay, so the correct answer for this question is option E. Why? Because here the patient is presented with DVT and stroke, and which is associated with paradoxical embolus, right? That would cause paradoxical embolus. Okay, why not option A? Because decrescendo type murmur that is associated with aortic regurgitation. We have noted in the previous question, you know, let me repeat this thing for you guys because this is really important. If let's say this is hard, right? Okay, here is the mitral, sorry, here is the pulmonic valve, okay, and here is the aortic valve, right? And over here is the tricuspid valve between right atrium and right ventricle, and over here is the um, mitral valve, right, between the left atria and left ventricle. Okay, now what are the sounds which are produced? Like over here, if these are considered as semilunar valve, right? In semilunar valve, if there is a regurgitation, right, that would produce diastolic murmur sound. That will produce diastolic murmur sound, right? And if again same place, if here is, if here is stenosis, like mitral sorry, like pulmonic stenosis and aortic stenosis, that stenosis would produce systolic murmur. What will that produce? Systolic murmur, right? Regurgitation will produce diastolic murmur, right? But the what is that called? See, the stenosis will produce systolic murmur. But this is opposite to the to the uh, to the case of tricuspid and mitral valve, right? It will be opposite. Like if here is regurgitation, that would produce, a systolic murmur. This is important. That would produce systolic murmur. So over here, in case of semilunar valve, regurgitation was producing diastolic murmur. But in case of mitral valve or tricuspid valve, regurgitation will produce systolic murmur. And if here is in mitral or tricuspid valve, if here is stenosis, right? Stenosis, that would produce a diastolic murmur. This thing is important. Okay, good. So let us continue from there. Okay, so it is as I talked about, it is diastolic decrescendo type murmur, decreasing decreases following amyl nitrate inhalation. So it is the case of aortic regurgitation, which is a decrescendo type murmur. Okay, okay. uh When used, amyl nitrate will cause vasodilation, would decrease systemic vascular arterial pressure and regurgitant flow to, so that will lessen the murmur. Okay, so it will decrease the murmur. So why not option B, ejection type systolic murmur that increase on standing? It is associated with hypertrophic cardiomyopathy, right? Decrease ejection systolic murmur in valvular aortic stenosis, right? Okay, so why not option C, presystolic murmur that disappears with a fibrillation, AFib? Okay, that is associated with mitral and tricuspid valve stenosis, right? Diastolic murmur with presystolic accentuation due to atrial contraction during late diastole, right? Since if here let me draw this. If it is the heart, okay, uh, what will happen if there is mitral, if there is tricuspid in mitral stenosis, right? That will pressure, that will increase pressure in the right area. Okay, so that will increase that sound. Okay, so that's why they are saying the diastolic murmur with presystolic accentuation due to atrial contraction. Since Atria has to to produce more pressure, since they will they have to work against thick tricuspid wall or mitral wall, right? Okay. Why not option D, mid-systolic click that occurs earlier with inspiration? It's associated with mitral wall prolapse due to reduced left ventricular volume, right? Due to decrease in venous return. What will happen in mitral wall prolapse, right? Let me, okay, let's say uh, it is located over here, so this will move in the backward direction. Okay, so that will reduce the left ventricular volume. Why left ventricular volume? Because there will be less venous return, right? Okay, so now let us move to the explanation. Okay, a cerebrovascular event, transient ischemic attack, stroke, setting of known venous thromboembolic disease is suspicious for paradoxical embolism. Paradoxical emboli originate in the systemic venous circulation, lower upper extremities, enter the systemic arterial circulation via an intracardiac or intrapulmonary shunt. They can occur in patients with patent foramen ovale atrial septal defects, VSD, or large pulmonary arteriovenous malformations. Atrial septal defects with left to right shunting, typically wide and fixed splitting, no change with respiration of the second heart sound. Mid systolic ejection type murmur over the left sternal border. You know, ASD. Let me draw this for you. ASD. Let's say uh, if this is the heart, right? Here it's ASD over here. It is located uh, over here. The problem is in this between both area. Their sound will be best heard. Let's say if this is the my drawing is very bad, but please adjust it. Okay, so let's say if it is sternum, right? Over here it is the first intercostal space between them, then second intercostal space, then on the left side we have the first intercostal space, then we have the second intercostal space. So what will happen here? Here it is on the right side, it is the aortic area, because there is crossing. I have talked about this, and the pulmonic area would be transferred over here in the second intercostal space, right? So that is also in the I'm talking about, let's say here is the first intercostal space. Here's, okay, here is the first, this one is the first intercostal space, this is the second. I'm talking about here, right? So this one area is the uh, pulmonic area. Here we can also hear the sound of ASD. Remember this thing, I have talked about this in the I talked about that trick, you know, that in the second intercostal space there will be the sound of ASD. That could be here, that would be upsystolic type. Then in the fifth intercostal space we have the sound of a VSD, right, in the area of tricuspid wall. Then in the same fifth intercostal space, but in the midclavicular line, we can hear the sound of mitral wall prolapse. So this is an important MCQ point. Remember this. Okay. So mid-systolic rumble lead to increased flow across the tricuspid wall. Paradoxical embolism uh, occur occur even in patient with net left to right shunt due to transient reversal of the shunt during periods of elevated right side pressure, early ventricular systole, straining during coughing or defecation. Okay. Why not option A? We talked about this early diastolic decrescendo murmur, aortic regurgitation, inhaled amylin rate, vasodilation, reduced systemic aerial pressure, regurgitant flow, lessening murmur. We talked about all those things. Why not option B? Systolic ejection murmur, increase intensity with standing. Okay. For example, in hypertrophic cardiomyopathy. What will happen in hypertrophic cardiomyopathy? Let's say if this is the heart, right? Here there will be thickness over here, right, in the left ventricle. So what will happen? Okay, in patients with hypertrophic cardiomyopathy, due to decrease in left ventricular outflow tract size, I talked about this. Okay, in contrast, the murmur of valvular aortic stenosis decrease in intensity upon standing. If there is the problem in walls, right? If there is problem in wall, then like here we have semilunar wall, right? If the problem is in those walls, then that would cause, that would be decrease in intensity upon standing. These are Valsalva maneuver. We will talk about that in the last. So we talked about this thing. That then why not option C, my mitral or tricuspid valve stenosis that will produce diastolic murmur? We talked about this. If there is mitral or tricuspid stenosis, that will produce diastolic murmur. But if there is aortic and pulmonic stenosis, that will produce systolic murmur. So mitral or tricuspid valve stenosis, diastolic murmur with the pre-systolic accentuation due to atrial contraction. We talked about this. With mild stenosis, murmur only be audible during the accentuation phase in the late diastole. If it may cause the murmur to disappear completely. Mid-systolic click of mitral valve prolapse earlier with inspiration. Reduced left ventricular volume, decreased venous return to the left heart. We talked about all these things. Okay. So paradoxical embolism, when a thrombus from the venous system crosses into arterial circulation via an abnormal connection between the right and left cardiac chambers, parent foramen ovale ASD or VSD, aerial left to right shunt cause wide and uh, fixed splitting of the S2 sound and can facilitate paradoxical embolism due to periods of transient shunt reversal during straining or cuffing. Okay, so these are important, which about which I was talking. Okay, so these are different maneuvers, and there will be change in cardiac parameters. Then there are some sound that, murmurs that would increase with those maneuvers, and some murmurs that would decrease with those maneuvers. Let's say with inspiration, what will happen, if someone inspire, right? What will happen? There will be increase in right ventricular preload, right? What will happen? There will be increase in right ventricular preload, but there would be decrease in left ventricular preload, right? If someone inspire, what will happen? There will be increase in right ventricle. Let me draw this for you guys. Okay, let's say this is the heart, right? Okay, so if someone is inspiring, the right ventricular, right ventricle, this is right ventricle, right? And here is left ventricle. The right ventricular preload would be increased, right? So the flow to the lungs will be increased, right? But flow to the systemic system, but flow to the systemic organs, right? That would be decreased. Okay, most of the right-sided murmurs, most of the right-sided murmurs that would increase, right? Why? Why? Since the right ventricular preload has increased, due to which there will be increased blood volume in the right ventricle, right? So if there is more volume, that will rush into the right ventricle, so that will produce more sound, more murmur, right? So most right sided murmurs that would increase with this. Most left sided murmurs would decrease with inspiration. Why? I talked about this, that the preload would be decreased, due to which the left ventricular blood volume would be decreased. So no blood, that much force, so less murmur sound. Okay, then we have Valsalva strain phase, uh, and abrupt standing, right? These are two different stage things. What is Valsalva strain phase? I have written this here. First, what will happen? We will say to the patient that take a breath. Okay, then close mouth. Okay, then But we will say to the patient, push out breath and strain for 15 to 20 seconds. Okay, but if whenever he does that, we will say to the patient, open mouth and breath out. Okay, if heart doesn't slow down, we will say to the patient, repeat it again. Okay, so this is our salva maneuver. Okay, and also with that, abrupt standing, there will be decrease in right ventricular volume and preload, and left ventricular preload, right? If we say to the patient that stand up, right, whenever he stand up, what will happen, the venous return will get low. Okay, so if there is no venous return, then the preload will be low, then the stroke volume will be low, then you know all those things will be low, so fluid will be low in the I mean to say the blood volume in the uh, right ventricle and left ventricle will be low. So if that is low, so the murmur will be low. Okay, so it is uh, uh, what will happen, the murmur that increases with these things are in cases of mitral valve prolapse, in hypertrophic obstructive cardiomyopathy, right, in mitral valve prolapse, in hyper uh, hypertrophic cardiomyopathy, right, because we're here, what is happening is, in these cases the left ventricular blood volume is already low, right? Okay, so uh, let's say let I have drawn this, if over here it is very thick, just like in case of hypertrophic cardiomyopathy, so there will be less cavity. Okay, but now we are also like we are decreasing venous return if a patient is standing abruptly, or he is doing Valsalva maneuver, right? So if that is low, right, so what will happen, that will further increase. Okay, good. What will decrease with Valsalva, strain phase and abrupt standing? Most valvular murmurs, most valvular murmurs, right? What will happen, that will decrease flow through in wall, right, decrease flow through wall, so that would be decreased, right? Okay, what will happen with squatting, right? It's a special type of exercise. With that, the right ventricle and the right ventricular and left ventricular preload would be increased, right? And with that also, this is important, left ventricular afterload would also be increased. Let's say this is a special type of exercise, I cannot draw this for you, please google it. Okay, what will does, the patient will sit in half. Okay, so what will happen, the uh, this preload would be increased, right? And with that, let's say this is left ventricular preload, this is right ventricular preload, like left atrium here, then into the, let's say this is the right atrium, okay, over here, then into the right ventricle, so preload would be increased. Over here, left atrium, then left ventricle, okay, preload would be increased. Okay, so what will happen, right ventricular and left ventricular preload is increased, sorry. Okay, so these two things are increased. What will happen with that, here the resistance to the outflow would also be increased. That resistance is given by afterload, right? So that would also be increased with this exercise, with this special type of maneuver, right? Okay, so the murmur would increase in most valvular murmurs. Okay, that would, that is what is the reason behind that? increase flow through wall. It will increase flow through wall, so that's why the murmur would increase. Okay, but the mitral valve prolapse in hypertrophic cardiomyopathy would be their murmur would be decreased. Why? Because of increasing in left ventricular blood volume, right? Since the problem where uh, there is less blood, less blood in them, right? So if we are increasing the blood quantity over there, right? So what will happen? The problem will be resolved. Whenever the problem is resolved, so what will happen? The murmur will get down, will get low. Okay, but here is in case of valvular disease, the problem is increasing with more flow. So with sweating, what will happen? We are increasing flow, right? So the murmur will increase. This is the opposite of Valsalva, strain, maneuver, and abrupt standing. Okay. Then we have passive leg raise, due to which right ventricular and left ventricular preload would be increased. We will say to the patient, or what we will do. Let's say if this is the patient lying down, what we will does, we will raise uh, his legs just like this one, right, over here. Okay, so due to which uh, what will happen, the right ventricular and left ventricular preload would be increased, since there will be increased venous return, right? That's why. Okay, that murmur would be um, increased. Again, it is associated with squatting, you know, with that squatting and passive leg raise, there will be increase in murmur in case of most valvular murmurs, right? Why? Again, since preload and afterload are increased, so there will be increased flow through wall, so that would be increased, right? And in case of mitral valve prolapse and hypertrophic obstructive or hypertrophic cardiomyopathy, since there is the problem that is having low blood volume, but here we are increasing, we are solving the problem with the passive leg raise, so that would decrease the murmur. Okay, last one is hand grip. We will say to the patient that hold your fist hardly. Okay, so what will happen, that would increase left ventricular afterload, right? And what it will does, it will increase the murmur in which diseases, in aortic regurgitation, mitral regurgitation, and VSD, right? Why? Because there is increase in aortic and left ventricular pressure, right? But it would decrease the murmur in case of mitral valve prolapse in hypertrophic cardiomyopathy, and would increase left ventricular blood volume, aortic stenosis, because it would decrease transvalvular pressure gradient, right? Okay, now let us continue the next question. A 40, a, a 28-year-old man comes to the emergency department with a 3-day history of increasing chest tightness, intermittent sharp chest pain. He also reports mild dyspnea, especially on exertion. The patient has no prior chronic medical conditions, but had an upper respiratory illness a week ago that resolved without treatment. ECG reveals sinus stack and low voltage QRS complexes vary in amplitude from beat to beat. Which of the following is most likely chest X-ray finding in this patient? So they are saying that increasing chest tightness and um, intermittent sharp chest pains, the patient was presented with history. Okay, then this patient is having mild dyspnea, especially on exertion. Okay, the patient was having upper respiratory illness that might be of acute type that was resolved without treatment. So this may be the case of viral pericarditis, and that is associated with pericardial effusion, right? And they have mentioned the symptoms of chest tightness and dyspnea on exertion that are also associated with pericardial effusion. Okay. Also with that, um, with the pericardial effusion, the symptoms are tachycardia, low voltage QRS complex, decreased heart sound, and electrical alternate. And it is a fibrinous or serofibrinous type of inflammation. Okay, so this one is the case of uh, because the heart is normally over here in the med, that is being increased. So this is the case of uh, pericardial effusion. Okay, which is associated with Coxsackie virus most commonly, right? We will talk about that. Why not this option? Since over here, uh, this length has been narrowed. We will talk about it. It is associated with COPD, right? Vertical cardiac silhouette. It is not presented with normal silhouette, right? We would look at that normal silhouette, right? Here over here, this has been decreased, right? This has been decreased. Okay, and there is hyperinflation. Like uh, normally the lungs are inflated till 8 or 10, but here in this case the lungs are inflated more than 10 reps, posterior 10 reps. Okay. Okay, so and over here diaphragm is uh, high, highly flattened, right? Okay. And one more thing is, in bronchial, in case of COPD, the bronchial markings would be increased, just like in this case. These things are not that much highlighted in case of normal uh, X-ray. Okay, this one is associated with bilateral pulmonary edema, which is patchy perihilar infiltrate. Okay, like normally not just like that much high haziness, right? Normal cardiac silhouette in the process of acute heart process like MI. If it is the case of MI, the cardiac silhouette will be normal, right? That MI would lead to acute systolic and acute systolic dysfunction and pulmonary congestion. But pulmonary edema in cardiomegaly is associated with chronic heart failure, right? This is important. If like in this case it is like not that much enlarged. If it was very enlarged, that would be associated with the chronic heart failure, and also the pulmonary edema would be present. Okay. Okay, this is associated with the right lung pneumothorax. We will explain to all those things that why it is associated with that. Okay, so sorry. And over here, the costophrenic, the lung is normally over just like over here, but here the costophrenic and cardophrenic angles are obscured, right? They are hidden here. Okay. As I talked about this, the normal cardiac size is less than or equal to 50% of transverse chest diameter, but over here it is very enlarged. It is enlarged cardiac silhouette and clear lung fields, right? And this is associated with the pericardial effusion. Okay. We talked about this. In COPD, the normal inflation is 8 to 10 reps visible, right? But over here Over here we can see hyperinflation greater than 10 posterior ribs visible, as I talked about. Increased bronchial marking, like normal not that much more, but over here we could see more, right? Okay. And with that, narrowed vertical cardiac silhouette, as I talked about this, normally it is not that much narrow, right? But over here narrowed, and our diaphragm is flattened, but over here not that much flattened, right? Okay. Bilateral pulmonary edema, we have patchy infiltrate. Like normally we do not have these things, these hazy things, hazy materials, right? Over here this is increased. Okay. And over here the lung is collapsed, like over here they have mentioned this haziness. This is not over there, just like over here. Let me draw this for you guys. Okay. Normally patient is not having these things, like these things. Okay, but over here they have presented with this case, so it is a collapsed lung, right? Okay. And over here is pleural effusion on the right side, right? So that's why it is showing white. Okay, that is because of fluid meniscus. So as I talked about this, the costophrenic and cardiophrenic angles is obscured. Okay. Okay, let us see to the explanation what the guys are saying. So pericardial effusion, uh, etiology, acute pericarditis, viral, bacterial, autoimmune, cardiac injury, MI, cardiac surgery, NC, metastatic spread of non-cardiac tumors, renal failure with uremia. Clinical features: dyspnea, chest pain, fatigue, possible cardiac tamponade. For example, tension, jugular venous distension, and with decreased heart sounds. ECG, there would be decreased QRS voltage plus minus electrical alternate. We would talk about this. What is electrical alternate? Since the let's say if this is the heart, right? The fluid will accumulated around the heart, right? So this heart will float in the um, in that fluid. So that's why that would change from beat to beat. Okay, we will talk about that. Okay, so chest x-ray, enlarged cardiac silhouette and clear lungs, right? We talked about this. Okay. Sorry. Okay, upper respiratory infection, viral pericarditis, complicated by pericardial effusion. Viral infection, most common cause of acute pericarditis, Coxsackie virus, type A, type B, and ecovirus. We talked about this thing. Most common organisms. These are the most common organisms. Pericarditis uh, typically experience chest pain, may be intermittent, often pleuritic and positional, relieved by leaning forward, right? Complicated by pericardial effusion, fibrinous or pseudofibrinous pericardial inflammation. We talked about this. Symptoms: pericardial effusion, there that would be chest tightness, dyspnea, and exertion. Due to decreased diastolic ventricular filling, that leads to decreased stroke volume, and also associated with tachycardia. To compensate for decreased ventricular filling, low voltage QRS on ECG and diminished heart sounds. Okay, to auscultation due to pericardial fluid accumulation, increasing the distance between the heart and the ECG leads or stethoscope. What is electrical alternance? Right? These are on ECG due to the swinging motion of the heart in a fluid-filled pericardial cavity, beat-to-beat variation in QRS axis. I talked about this. Okay. Enlarged globular cardiac silhouette chest X-ray, days to weeks. That if it occur in days to weeks, that would be subacute course. Allows large volumes, um, for example, 1 to 3 liter. Clear lung fields typically seen because the increase in pericardial pressure due to pericardial fluid accumulation affects the lower pressure right-sided heart chambers more than the left-sided heart chambers. Right? When right-sided obstruction to blood flow is greater than left-sided obstruction, pulmonary edema is unlikely to develop. This is important. Once again, when right-sided obstruction to blood flow is greater than left-sided obstruction, pulmonary edema is unlikely to develop. For example, they mean to say, if here I have drawn this, if there is more obstruction in the right side, right? So there will be less chance to develop edema, right? But if there is left side, if the problem is more, if the problem is less on the left side, so that would be easily go outside, so that would cause uh, peripheral edema, right? Okay. Option B, we talked about this: hyperinflated lungs, increased bronchial markings, chronic obstructive pulmonary disease. Option C, bilateral patchy infiltrate, perihilar is greater than peripheral. Okay, pulmonary edema. Normal cardiac fluid, as I talked about this, is associated with acute cardiac process, for example, MI, cause acute systolic dysfunction and pulmonary congestion. We talked about this. Pulmonary edema in the setting of cardiomegaly is associated with chronic heart failure. We talked about this. Absence of right-sided peripheral lung markings, small collapsed lung consistent with large right-sided pneumothorax, right? Blunting of the right costo phrenic angle and loss of diaphragmatic contour, characteristic of pleural effusion. Okay, so what is the educational purpose? Acute viral pericarditis, commonly complicated by pericardial effusion, tachycardia, ECG findings of low voltage QRS and electrical alternate, in large cardiac silhouette with clear markings. Thank you. I think it is enough for today. We'll continue from the next session. Okay.